So now we'll bring some of these pharmacologic concepts into the exercise and athletic setting. And we're going to connect some of the dosage requirements with exercise physiology and then work through a few cases that show why pharmacology knowledge really matters in the field. So here we explore some of the nature of exercise on drug metabolism, and the key idea being that the effects can be very complex and not always easy to predict. In fact, we have two categories there: light exercise and heavy exercise. And this is where we're going to try to make a connection to what we understand about exercise and the changes in blood flow patterns and drug absorption, metabolism, elimination, the things that we've talked about thus far. So during lighter exercise, blood flow to the gut and liver, they may support relatively efficient handling. They move relatively quickly, but absorption time is also decreased. So what happens when we transition to heavier exercise? Well, heavier exercise, we see a significant shunting of blood to the skeletal muscle. And this shift away from the gut and urinary tract means that now we might see slower movement through those systems. And this is why athletes' exercise routine can influence the viability and timing of medication, because less blood flow in areas where it would be normally metabolized mean less drug reaches the bloodstream, or we decrease some of the bioavailability in this standpoint. It's increased metabolism, and so these factors can impact. Now, because blood shunting away from the urinary tract also happens, clearance of the drug may be reduced. So the question would be, okay, which of these is going to predominate? You said if we have more drug spending time in the gut and liver, then it's metabolized. So there's less of it. It's less bioavailability. But then at the same breath, you said, well, wait a minute. We also see shunting away from the urinary tract. So that means we're going to actually hang on to more. Serum concentrations may increase. Oh man. Well, based on the evidence, there's not one effect that always predominates. So the most defensible answer is that it depends on the drug. It depends on the exercise intensity, the duration of exercise, the primary route of elimination. And during exercise, blood flow is redirected toward skeletal muscle and away from the gut, liver, and kidneys. But for many orally administered drugs, changes in absorption may be modest. But for drugs that depend heavily on the hepatic or renal blood flow, exercise can reduce clearance and increase serum concentrations. So clinically, I think it's important that we leave with this point, that exercise does not simply speed up everything, but it changes where blood's going. And as a result, the dominant effect depends on whether absorption, hepatic metabolism, or renal elimination is that limiting step or factor for that particular medication. So exercise changes the pattern of blood flow, and this is why we consider a number of different elements. You know, you've heard those phrases, well, don't go swimming after you eat a meal. Well, this is really because we have reduced blood flow to the gut. So you may wind up with stomach cramps. You know, you're not feeling so good because we have less blood going to the area where it would normally be digesting. So we just keep in mind some of these factors pertaining to how a person's feeling, and in some cases we might have to readjust or have the athlete go back to a provider to say, hey, this is my routine. So before an athlete is prescribed a medication, that person's exercise regimen should be taken into consideration. And we understand that that could alter the viability of the drug. And in some cases, the provider, the physician, may say to the athlete, monitor your signs and symptoms. We may need to adjust on days that you're participating in sport, or overall, we may need to change the overall dosing or the number of doses that you're going to be consuming in a day. So all of these might have a profound effect on some of the drug metabolism with exercise. And there's also key considerations of exercise metabolism pertaining to changes in plasma volume and protein concentration. So sweating reduces plasma volume, which can increase drug concentration in the blood. If it's being carried in the plasma, we have less plasma, then more drug is highly concentrated. If a drug is highly protein bound, this means that changes in plasma proteins may also alter availability. So physiologic state during exercise is not necessarily neutral, but it can change how concentrated the drug becomes and how available it is to tissues, right? We understand where does the water from sweat come from? From the blood. So sweating may increase the concentration of the drug in the body. And this is where we see a number of other considerations where drugs with low volumes of distribution, those can show a relative increase in serum concentration. Endurance athletes tend to develop an increase in plasma volume expansion. And because of that, there may be a lower given serum drug concentration. So these factors all need to be considered when a physician is prescribing medication or an athlete is participating in sport, because there may need to be an adjustment or a reconsideration of the dosing strategy. Now, some medication issues in exercise are very practical. If someone uses a nicotine patch, there is going to inevitably be an increased skin perfusion during exercise. And what that might do is it may increase drug delivery from the patch. So if a person is exercising and we see an increase in skin blood flow, now the patch is now getting into the blood with a greater intensity. And so we may have additional consideration or side effects that may result. At the same time, we see example number 2, where we have a person with asthma. And a participant with asthma who's using an inhaler for, let's say, exercise-induced bronchospasm, they're of course going to have an increased respiratory rate and depth, and those can influence the time course of the effect as well. So it is important to make sure that we have a consideration for these kinds of details that make the clinical knowledge useful in active populations. Let's make this case number 1. Now, we are presented with a 19-year-old sophomore who's given propranolol, and this is for test anxiety. It helps her feel less nervous, and if taken, immediately before an exam, it might reduce some of those negative side effects. But let's say now we have an athlete on test day who's feeling nervous, the test ends, and then goes to practice. But we had the propranolol on board. What should concern us here? Moving right from the classroom to participation in sport. So pause and think about this for a second. You can pause the video if you like. And if you were thinking that medication may still be active during practice, that's exactly the issue, because propranolol is non-selective as a beta blocker, and it can blunt heart rate response and affect bronchial function. And so the same drug that helps with test anxiety could create an issue for the athlete here if we're engaged in intense exercise. So we want to be mindful that an athlete who is taking medications, make sure their coach is informed or the medical staff is informed, their physician is on board. That way we understand, hey, in these situations, here's going to be the modified dosing strategy, or here's the structure that we're going to need to take if we know that exercise is going to proceed or follow the test taking event. Okay, case number 2. So here we have a type 1 diabetic. Type 1 diabetic who regularly takes insulin, and this morning took an insulin dose earlier than usual because of an upcoming track practice. Grabs a donut on the way out the door and heads to the track. So what concerns come to mind? And pause and think through if we have any of these considerations. And if you were thinking about a mismatch between exogenous insulin timing and the metabolic demands of exercise, you're on the right track, because insulin was injected. The body does not have the same endogenous regulation it would normally use, and that can create a dangerous mismatch during practice, because now we have an increase in hormones norepinephrine, which facilitates translocation of the glucose transporter protein to the cell membrane and increases glucose uptake. So we could see exercise-induced hypoglycemia. So for the athlete, the insulin taken before practice stays in the system for a period of time. There's no endogenous regulation or release and during exercise for a type 1 diabetic. This is a challenge for the insulin timing, and it might require some detailed glucose monitoring to ensure that if there is a drop, that we account for that with rapid carbohydrate planning and make sure that the athlete is going to be well cared for. And this is where all of these ideas become professionally relevant. So, athletic trainers, physicians, the coaching staff, everybody needs to be on the same page with regard to the understanding on not only the desired effect of medication, but the potential side effects, the tolerance, the dependence, the way that drugs influence exercise, and perhaps rehabilitation. So, long term drug use can change receptor behavior, and stopping certain drugs abruptly can create major problems. Whether we're skipping a dose, engaged in polypharmacy with multiple medications, pharmacology is not separate from practice, but rather it's a part of safe practice and gameplay. So the take home message is that medications do not act in a vacuum. Exercise changes physiology. Physiology changes drug handling, and that means anybody involved in this process, clinicians working with athletic trainers, active populations, the athlete, we need to be on the same page and think beyond the prescription label, but think how the impact is going to come about with the athlete and exercise.